Well, constipation, super common. It's a pediatric mainstay. And, I came up with a song, and I'm not a singer, but it's constipation, consternation, prostration. So it's a big issue. And with autism, it can be a big issue as well. So go ahead, Julie. Or Lindsay, sorry. So we'll talk about constipation and how ASD may impact that specifically. We'll talk about how we screen for it, what we can do in clinic. We'll look at treatment options real briefly, and then what daily management may look like for families. Um, so we think about definitions. I am a Bristol stool chart guy. I type into my Google search engine BRI, and I get Bristol stool chart instantly, not Britney Spears or somebody else that another search engine is going to pick up for a different person. But yeah, I get the Bristol stool chart. Proud of that. But constipation is going to be hard stools. They're either painful or hard to pass. And I hazard to talk about frequency of stools because every child is unique. But by definition, 3 stools per week or fewer than 3 stools per week is going to push you towards the constipation definition. But every child is unique and has their own stooling pattern. I've had a couple kids that pooped every 9 days and they were totally normal. Um, if we go on to think about impaction, that's when constipation's gotten more severe, more water is extracted from the stool that's in the GI tract, the large intestine, so the stool gets harder and bigger and is not going to pass. Without significant pain, tearing. You can see some decreased appetite because the kids learn that if I eat, it makes the gastrocolic reflex happen, and then you can see irritability in these kids. And then, of course, encopresis is when things are stopped up and you have new food that's been digested into a slush, and it goes through and passes the hard stool that's sitting there and leaks out through the anus. Next slide. So, if we think about constipation in children with autism, there's complexities and difficulties that are just intertwined with behavior and communication difficulties, and even with our diet. This complicates their management, and especially those that are nonverbal or with severe features of autism, they can be really difficult to see that it is constipation, but it may in fact manifest as just change in behavior. And so when you do have a change in behavior, really get at the stooling pattern of this child and do that first before you think about the other things that we would do with a behavior change. We know that kids with autism have a higher utilization of the emergency department urgent cares for the management of constipation over neurotypical children. And then there's multiple studies that show a higher incidence of GI symptoms in children with autism compared to the developing peers, typically developing peers in children with other developmental delays, not autism. And then, we have other studies that show the autism and GI disturbances can bring on anxiety and altered immune autonomic nervous system functioning. And this may explain the increased rates of GI symptoms in children with autism. Next slide. So special considerations, we talk with autism a lot about sensory abilities and oversensitivities. And so, some children just don't like the sound of the toilet flushing. This can cross over to neurotypical children as well. But with autism, you're going to see this more frequently, that the sound of the flushing is very disturbing. Um, they may, get a sensory input from stool in their diaper, the pressure there, the warmth there. And then also, on the other side, a negative experience sensory wise might be the toilet. Is it the right size? Is it cold, etc.? And then, kids are smart. They pass a painful poop once. And so they override the natural instinct so that when the rectum gets stool in it, a message goes to the brain and the brain says, hey, got poop, hold tight and go find a place to go poop. They send the message, but they don't listen to the message back, go find a place to go poop. So they get into stool withholding patterns when they have this fear of painful poops. Um, and then difficulty with change in routine, toilet training, um, you know, on the same toilet all the time is going to be very important for these kids. And then, using visual aids and making it a routine can be helpful. Next slide. So if we look at contributing factors to constipation, on the left you see all children, and on the right you see specific children with autism. And focusing on that, they have difficulty with transitions and rigid compulsive behaviors. Oftentimes, their low muscle tone impacts their ability to push stool out. They can have increased withholding behavior because of the sensory input. And then diet is significant because they can be selective eaters. They can have food sensitivities, gluten, casein sensitivities. You think about like decreased fiber with the typical, brown yellow diet of an autistic kiddo, chicken nuggets, French fries from the same fast food restaurant all the time. You hear that. And then, of course, anxiety can be more common in autism. And so that leads to issues around stooling. Again, if you think about neurodevelopmentally, the period of a child's life where the most child abuse occurs is during the era of potty training. So, it's super important to realize that this has a lot of anxiety for children and parents. So, next slide. Um, so when we're screening for constipation, with all children, we get that all the time, belly pain, decreased appetite, decreased number of stools. What does the stool look like? Spending a long time in the bathroom. We look for obstructive symptoms. With autism, we need to consider it from the point of view of what is their ability to communicate to us? What can they tell us about their stooling behavior? Abnormalities in sleep or eating habits can have an issue or an impact. And then behavior changes, get constipated, you might see self-injurious behavior, increase in tantrums, or even increase in aggression. And then, behavior and mood changes are highly correlated with underlying medical issues, and constipation is at the top of that list. And, they have an increased risk. So screening needs to be done like every time you see them. Next slide. Um, when we're thinking about communicating with autism families, say, did your child have a bowel routine? And very few children with autism don't have a bowel routine, or parents may have a routine that they don't know is a bowel routine, but it's a routine. um, you know, Look at any changes in appetite, mood, activity, behavior. You're hearing me say that over and over again, but it's so key. I've had so many kids with autism come in with some change in their mood or irritability level, and we treat their, stooling behaviors, and their irritability reduces back to a baseline. Again, do we have a change in sleep pattern? How long is your child in the bathroom? Get out the Bristol stool chart, and if the child can participate, have them dial a Bristol stool number. If not, get the parent. Questions about severe constipation would be: is the toilet clogging? Is there blood on the toilet paper? Do we see fecal smearing? And then, is there uncomfortable behavior prior to going to the bathroom? And then that is relieved by going to the bathroom. And then also with, constipation, you can get impairment of urinary flow. And so you're at greater risk for urinary stasis and then urinary tract infections. Next slide. So again, this is the Bristol stool chart. 1 and 2 we don't like. 3, 4, 5 we like more. 5, 6, 7 start to get abnormal. And so I find that asking people what their poop is like, especially kids, they're not going to tell you much. Throw in some communication difficulties, they're not going to tell you much at all. So when they can see a visual representation of their poop, it's much easier to point out. And plus, it normalizes that everyone has poop. And so lots of good information with the Bristol stool chart. Next slide. If we look at what we can see in physical signs of constipation, again, poor appetite, this may result in kids seeking out less food, and so we don't stimulate the gastrocolic reflex. Irritability again, and does it get better if we have stooling behaviors? And then abdominal pain, discomfort in those that can communicate that to us. And you may see posturing, either tiptoeing or arched back, straight legs, clenched bottom. Those are all signs that you'll see in autistic children. I don't think all tiptoeing is constipation, but you have to consider it. So, next slide. So if we think about treatment, very difficult, but you've got to think about obstructive symptoms, encopresis impaction, this requires a clean out. So oftentimes this may require hospitalization. In the past, we do this less often now. I'm not a huge fan of X-ray, but then again, I'm not a huge fan of rectal exams on these kids that may not be able to communicate very well their wishes in that department. So really physical exam, you can feel a malleable mass in the abdomen. A good abdominal exam can be very good at picking up malleable masses. Malleable masses I like more than solid masses, and they respond to treatment for constipation. So use of laxatives. So if you have infrequent large BMs, you can use stimulant laxatives to contract and move the stool through. Examples would be Senna or others. Then, lubricant laxatives to help stool pass. So glycerin suppository or mineral oil from above. So mineral oil doesn't get absorbed by the body, but passes through the GI tract and absorbed. And so kind of lubrication from the inside out. And recommended use limiting to improving stool consistency and frequency. Um, if we think about daily medicines we can use, so we're not obstructed, we're not having huge stools, we just need daily medication. We can think about the osmotic laxatives like polyethylene glycol or lactulose. Again, our goal is soft daily or every other day stools. I would even say if we're having a soft stool every third day, I'm okay with that. And then testing to consider for chronic constipation. This is the guideline: CBC, calcium, glucose, thyroid studies, celiac panel, hypothyroidism panel, Crohn's. We would only think about only if constipation. We would think about these only if constipation treatment response is less than what we expected. So we're treating and treating and treating, and we're having recurrent, constant problems. And then in those kids that are having refractory constipation, referral to GI is important. I know our GI specialists are overwhelmed with constipation visits from neurotypical children. When they see an autistic child, those are the ones that they really should be seeing because it's more complex and tends to be more severe. And the referral to GI may reduce your utilization of the emergency department and urgent care for the management otherwise. Next slide. So going on thinking about other things we can do, focusing on diet is super important. This is where referral to feeding therapy can be super helpful. OT can also help with picky eaters. Trying to think about dietary changes that might increase fiber in the food. You can hide fiber in food easily, but you always want to increase water intake if you're going to add fiber. Otherwise, you work to further constipate yourself. And then, thinking about behavioral changes, regular exercise is super important. And, we think about exercise, you going to the gym for the 90 minutes or whatever. We're not going to get that, but we can do micro exercise sessions throughout the day, and those cumulative have a good impact on bowel habits. We can do bowel habit training, find out what works for the kiddo, and then try to reinforce that. And then, access to bathrooms after meals is super important, and access at school to the bathroom is super important. Many schools have limited bathroom access, and so, you may have to intervene to allow that child with autism to get on their IEP, hey, bathroom access, free passes. If we think about supplements, we can use some bulk forming supplements, prebiotic, probiotic, and then, really medicine's going to help regulate stool frequency and consistency. And then when we're severe, we want to do the clean outs. And those are the ones that are not responding to the daily therapy and still having ongoing issues. Next slide. So, what is the benefit of fiber? Well, it promotes regular bowel movements and can help reduce constipation. This is bulk adding to the stool, and that creates peristalsis, which gets things moving. If you are adding fiber, gradually add it over several days, so it'll reduce the shock to the body, which can be seen in terms of gas, cramping, and bloating. And then, if we consider the different types of fiber, soluble fiber is going to act to pull water into the GI tract. stimulates peristalsis, but that keeps the stool softer by holding on to more of the water because the large intestine, again, one of its primary purposes is to bring water back out of the GI tract. If we think about insoluble fiber, adding bulk to the stool to keep it moving through the intestine and digested. And, there's some examples of that. And then combined soluble and soluble fiber, many foods are both, such as zucchini, oats, prunes, and plums. So I think I saw something in the chat, and we'll get to that in one of the next slides, I believe. Next slide. Um, so if we're thinking about meal planning tips for constipation, you want to try to include the thing that the child with autism will eat, but also put on some foods that will promote a healthy gut, like yogurt, kefir, miso soup, green beans, carrots, chickpeas, apple cider vinegar, probiotic drinks, juices, and then this is one that is interesting, the use of a hot beverage or hot cereal with fiber first thing in the morning. And the first thing I thought about hot beverage in the morning is that a sensory issue that some kids with autism are going to have an issue with. As stool frequency and consistency are improving, you can slowly add in fiber, 5 grams per day until age appropriate fiber needs are met. And you can do this with 1 to 2 fiber rich foods every 2 or 3 days. And then the water is just super, super important. You can constipate yourself just by diminishing your water intake. Autistic kids, if water is not their preferred, which is oftentimes their preferred drink, but if it's not, we can get into trouble with constipation just because of water intake. Next slide. So again, we talked a little bit about physical activity, helps the digestive system to stay active and healthy, stimulates natural contraction of intestinal muscles. Intestinal muscles, they contract efficiently and regularly, help move stool out quickly. If you have a large rest of stool in the gut, it stretches the smooth muscle of the large intestine, and then it's not as strong and not as able to contract. A muscle that's fully extended is not going to be able to contract very much versus a muscle that has a normal amount of tone is going to be able to contract more effectively. It's kind of like casting your arm, you get atrophy. If you have a large stool in the large intestine, it stretches things out and you get atrophy as well. And this is the exercise piece I was talking about. 10 minutes of activity several times per day is just as effective as a long session. And these will have health benefits in many ways. If you can get outside and do this, that helps to be in green space and get some sunlight as well. Variety of things you can do, tailor this to the specificities of the child and their favorite activities if you can. If you don't have any of those favorite activities, you can plan the day by like parking out further, taking the stairs rather than the escalator, things like that. Just kind of plan exercise in. I am not autistic and I park as far as away from the hospital as I can to go in every day just so I get some time outside and a nice little walk every morning and every evening. Next slide. So then if we go on bowel habit training, ABA, OT can help with this. Again, be patient with yourself and your child. Teaching new skills, especially this one is super difficult sometimes. And if anytime you're feeling frustrated, back off to the place you were comfortable because the child's probably feeling stress as well. So you feel stressed, child's likely to be stressed. Back off to where you weren't stressed. Child's likely to decrease their stress and be more successful at learning a new activity. Start out by sitting on the toilet. No expectations here. Just sit on the toilet, normalize it. If the kiddo normally goes behind the couch to poop, put the potty chair behind the couch. When you go to the bathroom, make it a big deal. Hey, go on number 2, here I go. So the kid sees this as a normal activity. This is one providing a quiet sensory environment for them. Do what's right for that child. Books, anything they can doodle with. I don't know. I'm not a huge fan of digital media on the toilet. But music, headphones, something that helps them mute the sounds of going to the bathroom might be better. But again, make it sensory appropriate for that child. And then, trying to let them be as comfortable as possible, choosing a toilet, that's the right size. I love Pete's Residency of Idaho. We have a tiny little toilet. This is the cutest thing for our little toddlers. I wish every home came with a toddler toilet and a big person toilet, but that would get difficult to enforce by code, I think. Um, and then picking a daily time for your child to use the bathroom. So a regular schedule is super important. And again, like if you can time that after meals where you have peristalsis naturally happening, you can move things through. And if you combine that with stool sitting, then you can have more success. Next slide. Um, supplements, considering fiber supplements, if dietary changes aren't possible. All of these supplements have psyllium, wheat, dextrin, or calcium polycarbonate, and those will all help out. And then to get to the question in the chat, the use of probiotic during acute symptoms can help. And this bifidobacterium is the one that's been most effective. And there's a link to the article where I got that from. Next slide. So, super important when dealing with any behavior with autistic children to have a care plan for this. Julie can help plan those. Julie smiles. She's like, "That's what I do. That's me." Having a care plan not only for when things are maintenance daily, but for when we lean to more constipation is more important. Normalizing the length of treatment. If I cast your arm for 6 weeks, it's going to take you a longer time than 6 weeks to regain full strength in that arm. The intestines are just the same. So we want to let parents know this is going to be chronic treatment. Talk about medication supplements that might be tolerable for the child and what's the goal of that medicine. Again, dietary changes, guidelines for fluids, and then emphasizing like, hey, if there's behavior changes, first think about, constipation as a cause. And then frequent monitoring is super important. Next slide. So this is my favorite part. We'll go off of a PowerPoint and just talk about constipation. I don't know if there's other questions in the chart. Yeah, just the probiotic one. Yep. Any questions? I think this is one of the things that I put in my template for my autism follow-up visits. I have a number of things that I have in there, but I like bowel regimen is one of those things on the template. In addition to sleep, behavior changes, therapies, medicines, um, wandering, safety. Questions?
Tom, it can be challenging to get kids enough water while they're at school. What kind of recommendations do you give to parents who are trying to deal with this issue in terms of they have no control over the school environment and they're not there, but that's a source of sometimes a lack of water intake?
Yeah, wow. I don't want to answer a question with a question, but Julie, have you been successful having this on an IEP for a family? That's the way I would hope that we could address it. And
They
I'm
would
just
be
not,
forced to do it if it was a accommodation on an
yeah,
IEP or a specific goal. I haven't seen that before, but I think that would be great in terms of if it's a severe concern and an
yeah,
ongoing chronic issue, then I think that would be great. Yeah.
yeah. If you think about it, kids are at school a long day. They're with their teacher and their providers at school more than their parents oftentimes. And so to exclude water during the day is going to be difficult. In a kiddo that had higher skills, you could have seeking water at times they can. If you had a kid that had severe issues and was refractory to treatment, I think getting water pass on the IEP would be something to advocate for. Thanks, Julie. I love that you're always thinking about the practical things that can help families. Travis?
Dr. Patterson, what one thing I find it's difficult sometimes with once I have a kiddo that's has impact or constipation, and then we provide treatment, that the treatment goes through a particular time frame, like a month, let's say, and then parents or providers will say, oh, this is now fixed, where we're not fixed, like the system still hasn't, like, what's the timeline? And then how do we explain, or maybe some tidbits on how do we educate parents on some of that?
Yeah, that is that part of the treatment plan. It has to be, you know, reestablishing what our expectations need to be. Um, and with autism, it's going to be chronic recurrent, unless you have a kiddo that has 6 months of feeding therapy, and now eats any food that's placed before them and says, please, may I have more fiber in my diet, which is not likely to happen. You're going to have a chronic issue. So letting these people know, and then again, like the simple act of asking every time they come in for a visit, asking about their bowel regimen. It only takes them a couple times to come up with a bowel regimen story. When you ask them every time, you let them know how important it is to you, and then it gets on their radar that this is going to be a chronic, recurrent issue that we deal with. And then in terms of the model of casting your arm, that really seems to help families understand. Like, if I cast your arm, your muscles are going to atrophy, even if I have that cast on for 6 weeks. Constipation with impaction took 6 to 12 months to get there. So you can imagine the time for those muscles to recover. And not only that, but the nervous system has to readjust, because when the brain is constantly sending the signal of got poop, go find a hold tight and go find a place to go poop, then the brain actually stops listening to the got poop signal. So you have this neurosensory disconnect with the intestine from the brain, because the brain got bombarded with got poop, got poop, got poop, but there wasn't a compensatory response from the body to listen to the brain's command. And so the brain stops sending that message. And so that takes time for the kiddo to have soft poops, which reinforces that it's going to be easy to pass those poop and it's not going to hurt me. That I keep things cleaned out and soft over time. And then that way the brain can start to trust the body again, that it will listen to the signal of hold tight, go find a place to go poop. But again, customizing this to the child is so important. But, in terms of letting the parents know, the expectation is this is going to be something I ask you every time, because this is just important as the behavior issues and may actually relate to the behavior issues. Because parents rarely call in and say, I think my kid's constipated and that's why he's upset. So it's our job to let them know the connection between constipation, behavior changes, and autism. And you can imagine, if you have a lot of sensory issues and you got this abdominal pain, and the thing that makes it better hurts you, it's a negative feedback cycle. So Julie, as a behavioral therapist, like expert, could talk that whole hour on how this negatively reinforces itself.
Tom, I actually have a quick question. I don't know, maybe it's not quick, maybe there's not a quick answer, but I actually had a family in my office yesterday where they're having a hard time getting their 5-year-old to potty train. There's a lot of elements and reasons behind it. Um, and I mean, I know potty training is somewhat behavioral, positively reinforced, shaping, chaining, getting to the point where they can actually use the potty. But then my concern is maybe there's a pain component, a sensory component, a constipation component. So when a family asks me directly, like, what do we do? Where do we start? Um, like, what do you think is the logical progression of things? I mean, do we rule out the medical stuff first and then we deal with like a behavioral interventionist or an OT? Is it a simultaneous thing? Like, what's like the best like approach from a timeline perspective?
Yeah, the starting point is the Bristol stool chart.
Mm-hmm.
One, identify, do we have hard stools? Do we have ones and twos? Do we have twos and sometimes threes? That is going to be the starting point. And if that's there, then I think you can look at what you can do to improve that. In terms of medically, if the child is passing the stools, that's normal. That's going to give you some education that the neurosensory input is normal. if you have leakage of stool, as was mentioned in the chat, parents will often think that's stooling, but that's just, fresh, you know, excrement that is still in liquid form that hasn't had the water taken out of it yet, that's leaking around the hard pellets and sneaks out. If you've ever had diarrhea, you know that the anal sphincter is good for solids and not liquids and gases. So kids experience this leakage when stool that had to rush through the GI tract because there was no space for absorption of water to happen. It gets there with lots of water and it's still in it, so it can leak out. I think going back, assessing the parents' level of frustration and educating them on going back to the place where they were less stressed. And is this a kid with autism,
Yes.
Helena? Yeah.
Yes.
So going back to the place where they were less stressed.
Mhm.
And then, I'm fairly sure OT can work with us too on stooling behaviors. Finding the right position. I think position of the body during stooling is super important too, and that's why the comfortable toilet is important. Flexion at the hip, flexion at the knees, feet solidly on the ground. That's going to be super important. You can suggest that if the child sensory wise can tolerate it, blowing through a straw while they're sitting on the toilet helps the anal sphincter relax. You got to make sure that's sensory okay with the kiddo. Every time I think about an intervention, I get so excited about it and I tell the parents about it and they're like, no go, wouldn't tolerate that. So you really have to customize it, but the straw is, oh, pinwheel, that's another great thing because you would be blowing through the lips, pursed lips is a way that our magical bodies release tension in the anal sphincter.
I never thought about the low tone piece because this little guy is pretty low tone as well. So there's
Yeah.
like so many things, attention, focus, being perceptive about their sensations. I mean, there's so many variables here. And kind of like what we try to do with Echo, I try to give like, what are the three things? We can only just need like maybe three things to try, and where do we start? And how well does their primary care know to do all of the steps from the medical standpoint? So it's a little tricky to advise all of that, but these are nice. It's nice to have some of kind of a kind of a guidebook as to what to tell them and where to start. So
Yeah, can I have four things?
sure.
Um, so number one is the Bristol stool chart.
Okay.
Normalizes so families can self-identify when there's trouble.
Okay.
Number two is dietary and behavioral changes.
Okay.
Number three is medicine. And number four is follow up, follow up, follow up, follow up, follow up. Always,
Okay.
always, always, reinforcing the expectations of what our goal is of the treatment and how when we're not treating effectively, these are the consequences and behaviors, one of the top ones. And Julie, if you found out that your child had a behavior that came from some cause, how long would it take you to remove that cause?
You mean a
You'd be
negative
on it right away, right?
association? Yeah, yeah. We were taught always to rule out the physiological issues first, but if they've paired up like the bathroom is a negative place or pooping is a negative thing, then we need to repair that with something positive. And so you might have to overcorrect a little bit with lots of positive things in the bathroom. The Elmo videos, put that special reinforcer in the bathroom so they can see that it's in there. I try to move everything into the bathroom first. When I'm approaching potty training, it just depends on the parent, how much time they have, the kiddo, all the things that Tom said. But like start changing the diaper in the bathroom and associating all things poop with the bathroom. And that's usually my first step. But yeah, it's definitely an individual case by case basis. Tom, I'm curious, toilet training readiness. In a typical child, you talk about all these different signs of toilet training readiness. Doesn't always look the same in autistic children. What do you tell parents when they ask you, like, is my kid ready for toilet training?
So thinking about a neurotypical child, really interesting data. In Europe, you learn to potty train around the time you learn to walk. you learn to walk around a year of age, and around every year of age, kids have the ability to process two things in their brain at the same time. And so those are really the fundamental things we need is, um, I can hold two things in my brain and I can walk to the toilet. In autism, that's going to look different. So you have to take the developmental stage of that child and adjust it. They're having gross motor issues in addition to all their fine motor and sensory stuff. Then you may have to adjust that. But customizing it to the child is going to be the most important. But then also, really, really profound that the number one highest time of child abuse in a child's neurodevelopmental progression is potty training. That's the one milestone. So when you let parents know that, suddenly it seems like you can tolerate a lot more. Letting them know it's going to be hard, but letting them know that it's possible.
Thank you for all of the wisdom and good conversations today. I really appreciate it. We are going to come back for our Echo Autism series on February 13th from 12:30 to 1:45 Mountain Time. The topic is augmentative and alternative communication tools. When are they helpful and appropriate? We have Ann Kohlmeyer who will be joining us. She is our guest presenter coming from St. Luke's Health System. So we hope to see you February 13th. Take care. Be well. Bye.
Bye, all. Take care.